Good evening, everyone. On behalf of Indian Association for Bronchology, I invite you for the IB Basic Bronchoscopy Certification course, which is going to have 12 online modules and one hands-on workshop. We've finished 10 online modules. This is the 11th in the series. And I should say that we have kept the fireworks for the end. As the name suggests, today we're going to talk about hot and cold therapies and stenting through fiber optic bronchoscopy. And for such a elite discussion, we have an elite panel. Before we go to the panel, we have an important talk. And it is my immense pleasure to invite Dr. Arjun Srinivasan to give his talk on hot and cold therapy. Can you put up his slide, please? Dr. Arjun needs no introduction in the pulmonology or IP fields. He's a consultant pulmonary and critical care physician at the Center for Advanced Pulmonary Interventions at Royal Care Hospital, Coimbatore. He has over more than 15 years of experience and has presented multiple papers and has multiple publications. And I hand over the mic to Dr. Arjun for his talk.
Okay, very good evening, one and all, and thanks to IAB for the opportunity. And over the next 20 minutes or so, we'll be looking at how do we use hot and cold therapies and how do we stent using a flexible bronchoscope. So basically, you've been through 10 webinars now. We are basically stepping up your game. And these are serious tools in your armamentarium. And first thing that we need to know that whether you're using, if we are not using a rigid, but you definitely need to control the airway. And the control the airway in terms of a lot of these things. I will mention where things can be done without, but by and large, you need to use it's easier to when you control the airway, which can be using either ET tube or an LMA. You need not be using rigid, but that doesn't mean that you don't have to take the patient's sedation deeper. And let's lay the thing to rest, rigid versus flexible. Controlling the airway is what is important, but a word of caution here when you're using these advanced procedures is that, generally flexible when done alone requires more skill than if you're using it through a rigid, because basically you're using rigid as a conduit and it is less forgiving because of the fact that you do not have enough space for a lot of your instruments to go in if you do not have a rigid bag. As far as between ET tube and LMA is concerned, this is a small diagram as to what happens. What is the surface area of the trachea, which is usually around 2 centimeters. The area works out to around 3.1 centimeters. Even if most of our patients will not take more than a size 8 ET tube, the area of the tube drops down to 0.5 centimeters square, of which your therapeutic scope, which is around 6 mm, will occupy more than 60% of approximately 60% of this area, which means that when you use a ET tube, the effective area for ventilation is equal to only about 8% of the available area. So by and large, if you want to use a conduit, it is preferable that you use over the cord airway, like a laryngeal mask airway, rather than a ET tube, because it sort of interferes with whatever you're doing and it compromises ventilation to a large extent. So when whatever we're going to be dealing with, all the three things, we're going to be looking at the diagnostic, which is getting a biopsy, whether it's either endobronchial or transbronchial biopsy. And we are also looking at whether these instruments can help you in handling the complications post-biopsy. Therapeutic, of course, you're going to be looking at debulking, dilatation, handling bleed, and of course, restoring lumen. So let's start with the cryotherapy. Let's not get into too much of theory here. It basically works on the principle of Joule-Thomson effect, which means that there's a rapid cooling occurs because of expansion of the gas. Usually liquid nitrogen or carbon dioxide is used, and the temperature to which it cools down is about minus 90 centigrade. And it needs a source, which is you need to have a cylinder there. And the machine is by only RB at this point of time. And we have 3 different probes that you can use, which is the size of the probe, which is 1.1, which will go even into your the smallest bronchoscope having a 1.2 channel. but again, you will not have much space around that. 1.7 is typically used for both diagnostic as well as therapeutic work, and 2.4 is primarily used for therapeutic work. Here, it does not essentially mean that the bigger is better in terms of as the probe becomes bigger, it requires a bigger scope for you to use it, because these essentially go through the scope. And when there is hardly, even with a therapeutic scope, when you use a 2.4 probe, there's hardly any space left around, which means that you may not be able to get any suction around the catheter, and also makes the scope very stiff. So the users are typically for biopsy, which can be endobronchial biopsy. If you have a foreign body, it can be retrieved using a cryoprobe. It can be used for recanalization as well as for transbronchial cryobiopsies. So this is where you can do an endobronchial biopsy. Again, you can see that this is 1.1 probe which is being used. And one more reason as to why you need a conduit is that the probe does not come into the channel. You have to take the thing N block, even a 1.1, unless and until using a dedicated catheter for that, which means that you will be doing multiple trips from the point of interest back to sort of deposit your biopsies. And even if the patient has got a controlled ventilation, you're going to be losing sight of the place where you have taken biopsy for a minimum of 12 to 15 seconds, which means that there can be a significant amount of bleed. And especially if you're doing it without a conduit, here you're going to get into a lot of trouble if you have bleed. So if you look at using it for cryo has actually redefined the way in which we handle foreign bodies in young kids, wherein you can retrieve even without rigid. And again, these patients need to be under some form of GA, usually with an LMA again. And you can see that here the most important thing is that you should not be touching the mucosa, and you have to be touching only the foreign body, which can be retrieved. And again, it is very useful in retrieving organic foreign bodies. But if you have a metallic foreign body there, the cryo does not work. When you use for endobronchial debulking, this is a patient wherein there's a lot of voice stent which has been removed, and there is a lot of granulation which is obstructing the right main bronchus. Here you'll have to do multiple steps, and for we would not be doing here. The conduit that is being used is a rigid bronchoscope, but of course you can use either an ET or an LMA as a conduit. The principle sort of remains the same. You can see that every time it comes out, it actually avulses the tissue out, and you need to make multiple trips. And each time, despite the fact that you're using a 1.7 probe, here the amount of tissue that comes out is a part of whatever tissue is available. You need to make multiple trips to make sure that the entire tissue is debulked out. When you do a cryo-TBLB, so this is depiction. We'll be using it under fluoro guidance. Here you'll need to make sure that in that segment you've got both the cryoprobe which is going inside, as well as the Fogarty catheter which is there, to make sure that there is not much bleed. So this is extremely important. In addition to having a conduit, whenever you're doing a cryo-TBLB, you need to have a balloon in place. Usually it is the Fogarty catheter. When you use the fluoro, you can see both the Fogarty, which is blocking that segment or that lobe, and the cryoprobe, which is positioned a centimeter at least away from the chest wall. And then you can freeze it for anywhere between 3 to 5 seconds. Then the catheter is left in place. The Fogarty catheter is left in place while the cryo is taken out through the conduit. And when this is happening, the person who is assisting you will make sure that the Fogarty gets inflated when the tissue is delivered outside. This is the Fogarty catheter or the balloon, which is giving a tamponade effect, and then subsequently the biopsies can be taken out. This is we need to be very sure that ideally you do it through a rigid, but if you're doing it through an ET or an LMA, you make sure that that segment where you're taking a biopsy, there is a balloon tamponade, because for 12 to 15 seconds you're going to be losing sight of the bleed, and sometimes the bleed can be quite significant that you may not be able to go back and tamponade that segment. So these are the cautions that we need to use while using cryo. The probe and the scope, you need to come out en bloc. We've seen it in all the case demonstration. Never insert the scope through the nose, because if you are doing it in that case that you're doing it without, say, only a conscious sedation patient without a conduit, you always make sure that you take the scope through the mouth, because you're going to be coming out with the probe. And when the probe gets activated, after 3 to 5 seconds, it can still stick to the mucosa, and it has to be a smooth way out. And like I always said, use a conduit, ET tube, rigid, or an LMA. Tissue gets avulsed. You can see that the tissue is getting avulsed, and therefore the tendency to bleed is quite a bit, and it takes time. So the minimum that you will need is about 12 to 15 seconds from the time you leave the endobronchial space when you are back into inspect. So this is something that you need to be very careful about. Let's talk about, so this is only, cold therapy that you're going to be talking about. So you're going to have what is called as an argon plasma coagulation. It's a non-contact mode of coagulation. So it's basically, use of argon gas, which conducts the electricity, and it can be superficial and cover a lot of area. And it is basically a method which we use to contain bleed. And it is not a great modality to debulk tumors, but it is excellent modality, especially if you have a diffuse sort of wound. And it comes with 3 catheters. This is the tip firing catheter. You can see that this is a patient of a Dolovois lesion, and you can see there is a pinpoint area of bleed. And this is something that you need to be sure of, that whenever you see a patient present with hemoptysis and you find this sort of very innocuous looking small nodule, this can very well be a Dolovois lesion. And here an APC, which is a non-contact, you're not touching the lesion, and you're able to achieve hemostasis with the APC. Again, this is a circumferential thing wherein now this is a tumor bled where the tumor has been debulked, and you see that only the place, it seeks the place where there is ooze or where there is bleeding. And you can see, though it's a circumferential thing, it only is firing at the point where there is a raw area or there is a little bit of ooze, and it does not fire in the area where where there is a normal mucosa. So this is a demonstration of the different types of probes that you get with an APC. Again, whenever using any thermal technique, you have to be sure that your FiO2 requirements are less than 40%. And here now you can see that there are multiple black marks. And for the sake of the safety of your scope, you have to make sure that you at least see one of these black marks, so that it doesn't damage the scope. Here is a side firing APC. Again, this is a patient of CA thyroid, and you can see that the tumor is bleeding, and this is a side firing APC. You can direct it. Sometimes it can be a pain to direct it to that extent because it keeps rotating. And once you direct it to that tumor bed, so you can see from all the 3 cases wherein the APC is being used, it's an excellent tool when you have a surface ooze. It's also a very good tool when you have a place where you have a endobronchial bleeder. You're able to identify the endobronchial bleeder, and APC can be used to control the endobronchial bleed. So it's a great addition to your armamentarium. It predominantly is used for homeostasis. Again, you have to make sure that FiO2 is less than 40%, and the depth of penetration is extremely superficial. So it covers a large surface area. It seeks the place where the ooze is happening, but it is not a great tool for debulking. Now comes the poor man's tool for debulking. Electrocautery is something that all of us have access to. Even if you do not have it in your bronchoscopy room, you can have access to the electrocautery machine from your surgery friends. And this is cheap and readily available across the hospital. In any multi-specialty hospital, you need not go far to find an electrocautery machine. It is low maintenance also. It does not have a lot of costly consumables. It is, of course, easy to learn. There is less risk for perforation as against a laser. And it has got an immediate effect, and it's got a much better depth of penetration. So you can actually use it for debulking tumors. So there are multiple accessories that come with an electrocautery. This is a blunt probe. Again, the electrocautery also, you have to make sure that the FiO2 is less. Again, you need to make sure the probe is sufficiently out. So this blunt probe, you can see that it is way back from 2011. The video is, you can see for the surface control of bleed, it can be used. But what happens is it chars the tissue and gets stuck. So usually what happens is it gets stuck, and when you try and take it off from the tumor, it starts oozing again. Like you can see that it takes more time than APC, whereas the APC is non-contact. If you remember from the demonstration of APC, you can see that the APC is kept a millimeter away from the bleeding lesion, whereas in a blunt probe you have to touch the bleeding region to try and control the bleed. So the other thing is a hot biopsy forceps, again from way back more than 17 years ago. It is basically a cup forceps which has got an electrocautery attachment to the proximal end. What you do is when you find a vascular tumor, and this is what we used to do back in the day, when you find a vascular tumor and you want to take a biopsy, you go ahead again, make sure that the black part is out. You go ahead and take a biopsy of the lesion, and you hold the lesion, and when you're closing at this point of time, you go ahead and plus the electrocautery pedal. And what happens is that the tip of the cup, when it closes, it will char the tissue there, and it will achieve a coagulation so that the vascular tumors have less tendency to bleed, and it will also cut. It is not an avulsion that happens, but of course you see that there can be a little bit of ooze despite that, and you need to time. So again, a cooperation between you and the person who is using the electrocautery and the APC is extremely important, because you need to ask them to fire, and when the probe is in position, and they have to fire, and when you ask them to stop firing, they have to stop firing. And similarly, it is here at the right time, they have to close and fire, and then you will be taking the biopsy out. So this is the electrocautery knife, which is excellent tool if you have a web-like stenosis. This is a post-transplant patient, bilateral webs you can see. And when you're using this, you have to again make sure that the entire knife is out. And this has to be followed with a balloon dilatation. You can see the suture line there. Whenever you're using a knife, you have to make sure that the knife is out, the FiO2 is down, and you always do only the anterior or the lateral wall, and it cuts and it has to be a very short burst. So either you can control the electrocautery pedal, or you can ask, if you have a good coordination with the person assisting you, then they can control. The FiO2 is down, and you have to absolutely make sure that the knife is entirely out. And you can see that initially the anterior wall was taken, and then subsequently the lateral wall again. The left side also taken. This, when it is done before a balloon bronchoplasty, will give the direction to the balloon and make sure that the posterior wall does not tear. You'll never use an electrocautery knife on the posterior wall of the either trachea or the bronchus, because you can cause a significant injury, especially if you're using on the posterior wall. You can cause an esophageal injury also. So electrocautery snare, this is something that you can use to achieve debulk large tumors, especially tumors which are pedunculated. And again, you can see that the patient is not very deeply sedated, and there is a lot of respiratory movement which is there. It comes in multiple shapes. The thing that is being used is oval. You'll have to try and get most of the tumor in one go and try and close it around the base. That is what is being done. You can see that it is being closed around the base, and once it is properly closed, then the electrocautery gets fired. Again, FiO2 is low, and what happens is that it cuts and it falls away. So you have to be prepared when you're using this, especially in a conscious patient, that you need to have something else to pick it up. Electrocautery snare cannot be used for picking it up. You can use a cryo to pick up tissue which gets dropped inside, and the patient is conscious. The patient can sometimes cough out the tissue also. Here a basket is being used to retrieve the tissue. The cons of electrocautery is you need to maintain low FiO2, causes significant charring and tissue destruction, can promote tracheal stenosis. Yeah, again, if you are not careful and if you are hitting the native trachea, not the granulation tissue, and if you use it excessively, it can cause a significant amount of, you can actually cause more injury than what you are trying to treat. It can cause smoke, as well as clouding of vision. So you have to be careful. and the FiO2 being low, that you need to keep low, cannot be stressed enough, especially because these patients will be under GA. The thing that we generally tend to do, practical thing that we generally tend to do is just before the patient is usually about what 50 to 60% FiO2, unless and until the patient is very hypoxemic. When we are preparing and when we are pushing these electrocautery catheter or an APC through the scope, we'll ask the anesthetist to disconnect. When the patient gets disconnected from the circuit, that gives you enough time to make sure that the FiO2 goes down. So this is the practical tip that can be used. And it cannot. One thing electrocautery cannot do is you can cut through tissue, but it does not vaporize tissue. The vaporizing tissue is only done by laser, and coagulation property is slower than laser, so it is not very effective in coagulation. But especially when we looked at these polypoidal tumors, when you use a snare, what we generally tend to do is we use short bursts of coagulation. Though we want to cut through this, we use cut coagulate in alternate. We either use cut and coagulate alternatively, or we just use coagulate over a period of time and will slowly close the snare. So this is one way to make sure that the coagulation is adequate. It should not be like you use a snare and you open up a vessel and you have a significant bleed. So laser, this is not something that we have access to, and it's a non-contact method like APC, but it has a much deeper tissue penetration. Actually, it has got a very deep tissue penetration, so you have to be mindful of the anatomy. You can injure the underlying large vessels also. You need to have an eye protection for all the personnel who are there inside. The thermic effect depends on the distance, power, and duration. So this is something that you need to be mindful of. Coagulation is between 10 to 20 watts, whereas vaporization and carbonization between around 40 watts. Nd:YAG is the most commonly used, but Nd:YAP can also be used. So this is the small thing. This is the cartoon and videos courtesy Dr. Harve Dutta, and you can see that again. He tends to do everything using a rigid scope. You can see that the edge of the rigid scope is here. This is how the laser works. It basically cauterizes the underlying vessel. You can see that there is a large bleeder. What you see here is actually the suction catheter. The rigid suction catheter can be very effective in giving you a good lumen. This is the laser fiber that is coming in. And what is being done is you have to be parallel to the wall to make sure that you have a control over the depth of penetration. And once you are parallel to the wall, you can slowly see that the ooze, the rate of ooze is slowly coming down as the underlying vessel is getting coagulated by the laser. You can see that it is reduced to a trickle now. And the large suction catheter is what makes sure that you have a very clear field of vision the whole time that the laser is active. You can see, again, these are the effects of laser. The laser is being very, very parallel to the wall, and here you manage to completely stop the bleeding. So it's expensive to procure. There are only a handful of centers across the country. You can probably, if one of your colleagues or the fellow departments have an access and it is compatible, you can try and see whether the laser can be used. It also has a high running cost because the fiber sort of gets consumed as and when you use. You'll have to, once it is done, you'll have to cut off the tip, and that also means that you'll run out of fiber, and this adds to the consumable cost, personal training, and need for special gear for everyone in the room. It's got a high depth of penetration, can cause perforation. It's one of the very few interventions which has got the significant risk of airway perforation, and of course scope as well as airway fire is always there. This is where we stop in terms of both cold and hot therapies. I've also been asked to talk about stents. Stents will be only talking about metal stents because we'll not be able to deploy any silicon stents through only using a flexible scope. So placement of SCMS can be either done with a rigid bronchoscopy or a flexible bronchoscopy. So we'll need to know the difference. In a rigid bronchoscopy, like I have been ranting and I've been talking about for the last 15 minutes or so, it's got a better control of airway. It's got a better ability to ventilate while performing the procedure. It's good for managing bleed. We can even core with the bevel so that you get a better lumen. now flexible bronchoscope can be introduced. So again, most of the so-called archaic rigid instruments are not used anymore. Now, most of these things are being used by a flexible, by instruments that can pass through the flexible channel, because that gives us better maneuverability inside. So basically, using rigid was only a conduit. Whereas the flexible bronchoscopy is more widely available, and you can technically place stents with no need for general anesthesia and lesser cost when compared to a rigid bronchoscopy also. So I'll not dwell a lot on this slide, because I'll try and see whether I can show you in a demonstration. So it has to be, of course, done orally. You cannot do it through the nose, and you need to have a thin scope to look at what is happening. And you need to have a very stiff guide wire, and we'll get to as to why that is so. And of course, you need the stent, you need a laryngoscope, you need McGill's forceps, and of course, you need a crash cart, because just in case if you do not, you are not able to do it, and you need a forceps to manipulate the stent. So this is a demo in a mannequin, because we looked in our records and I couldn't find anything that we have done with using only a flexible bronchoscope in a long time. So in a mannequin, first thing that you need to do is, let's say there is a stenosis here, you have to go initially through the oral route, place the guide wire beyond the stenotic segment. Once you place the guide wire, this has to be extremely stiff guide wire. I'm stressing this part that it has got to be stiff guide wire time and again, because of what you're going to see next. So once the guide wire is placed, so you're threading the stent. This is why it is extremely important. You can see that it's a very, this is about 6 mm at least, and it is extremely stiff. The stent deploying apparatus is, unless until you have a very stiff guide wire and you have a McGill's forceps around. And imagine this patient is conscious and breathing and also has a tracheal stenosis or a stricture, for which you are placing the stent, and it is quite difficult to get beyond the arytenoid, even with a stiff guide wire. So here you can see that there is a forceps or a McGill's you can use to try and push it inside. And once you push it inside, you need to have a very thin sort of scope. Here you have, let's imagine that you've gone beyond the stenosis, and once you've gone beyond the stenosis, you are able to deploy the metal stent under vision. So this is the metal stent which is being deployed under vision. Here you can, you have to make sure that, this, or usually you have a marker which tends to be either black or yellow in color. You visualize that marker, and the marker is kept above where you want the proximal part of the stent to get deployed. And this is how the stent gets deployed. You can deploy the entire stent, and till you deploy about 50% of the stent, you can still manipulate it up and down, so that you get it in proper position. And again, like I said, when you're doing it only with flexible, it is less forgiving, because if you do not deploy it in the right position in one go, it becomes a little bit more challenging in a patient who is spontaneously breathing to sort of manipulate this stent. But things have changed, courtesy Dr. Janaki, who trained with us and is working in Chennai now. But you can see that you got stents. So this is a bronchial stent that is being deployed for a patient who's got left main tumor, which has got an intrinsic as well as extrinsic component. So you've got these newer stents which can be deployed through the flexible scope. So these are thin stents. At this point of time, you have only straight stents which are deployable this way. Again, she has reached the distal end beyond the tumor. And this is the entire stent with the deploying apparatus which can go into the channel of a therapeutic scope. And you can see that the stent is being deployed, a flexible stent that is being deployed through the metallic stent which is being deployed through the flexible scope itself. And again, sufficient amount of stent has been deployed proximal to the tumor to get an adequate lumen. Again, if we thought placing a straight stent with only a flexible is a challenge, try placing a metallic Y. Again, going through our records, we've not done it in a long time. This is a video courtesy. Shout out to Dr. Rajiv Goyal. And now, again, similar thing here. There are multiple techniques of doing it. There are ways in which you can use two stiff guide wires of different colors, one on the right and one on the left. Dr. Rajiv prefers to do it with only one because sometimes when you use two, they can sort of intermingle with each other. Again, through the oral route. Once the guide wire is placed in the left side, the left arm of the Y stent is threaded into the guide wire. Again, this is the patient who is breathing, minimal sedation maybe or no sedation, just local anesthesia. And you can see that the guide wire, when the here again, Dr. Rajiv has published over 30 cases, and you can see that he's able to expertly maneuver it inside through the vocal cord. Again, you need to use a thin scope. When you use a thin scope, there's a lot of lesion. No, the suction may not be great. And these patients have to be relatively stable. If you have got a crashing patient, this will not be a great case wherein you can do. But though there is a significant involvement of both the trachea as well as the left side, here you can see that the left side is being maneuvered into the left main along where the guide wire was placed. And here under vision, you can manipulate it, and you can see that the right limb has gone inside the right side. And once this is there and you are sure that you are on the carina, at this point of time, you can use a fluoro also to make sure that you are over the carina. And once this is done, the string is pulled to make sure that, again, fluoro can be used to confirm that the left and right has been deployed. And then the tracheal limb gets deployed. And you can see that the stent has been deployed perfectly, and only the left guide wire was used, and you can see it is sitting snug over the carina, and the left and the right stenosis have been, the right upper lobe is visible, and when you look at the distal left main, it is well beyond where the tumor was. You can see that it has passed the tumor and the patient has achieved a sufficient large lumen. Okay, and this brings me to the end of my talk, and these are basically big boys or big girls tools. These give you a great power, but with great power comes great responsibility. You have to use it responsibly. None of these tools are great on their own. You need, with time and with experience, that how you can mix and match. They're complementary to each other. One tool sort of complements the other, and all these tools have replaced the rigid forceps that we were forced to use. We only reach for the rigid forceps if we have to retrieve or take a stent out these days, and we do not use it for anything else. And now a cryo has replaced most of it. It gives you you need to have a good airway control. It reduces the anxiety. There is always a thing when you're starting off, whether you want to use an LMA, whether you want to involve an anesthetist. But what it does is, it lets you work in peace. The airway is managed by somebody else. The anesthetist is there with you. It gives you time to do the procedure properly. And of course, like with everything, team is needed for a successful procedure. You need to have a very good coordination, especially when you're using either a cryo, when you're deploying a stent, or using an electrocautery, to make sure that there is a good understanding as to what you're trying to do and how the person who's assisting you is. There has to be a good coordination between both of you. Thank you.
Yeah. Thank you, Arjun sir, for excellent overview of all the modalities that we do in advanced IP. So now we move on to the panel discussion. And my first question is to Dr. Rakesh. So we have heard a lot about this stenting and other things, but the important thing, before that, I'll introduce Dr. Rakesh. Dr. Rakesh is the currently working as
it's okay. I think then we can move ahead.
Yeah,
Okay.
I'll just give a brief introduction. So
Sure.
Rakesh is currently working at Birla Hospital in Jaipur, and along with that, we have other set of panelists. We have Dr. Rohan, who will be joining us a little late, and he's a senior consultant at Apollo Hospitals, Navi Mumbai. And then we have Dr. Saurav Pahuja, a dear friend of mine, and who is at Amrita Hospital in New Delhi. And finally, we have a young and dynamic women interventional pulmonologist, Dr. Divyashri. She is currently working as a consultant Manipal Hospitals in Bangalore. So with this, we move on to the first question to Dr. Rakesh. So, what is the sort of the anesthesia you generally prefer for most of these cases of complex airway interventions? Like, do you always prefer only semi-consciousness, or like or would you go for a general anesthesia as a routine for all these procedures?
Right. So, good evening, everybody. And just as Dr. Arjun has shown the cases, and I was seeing that with the rigid and general anesthesia, and also later on that some of the cases with the conscious sedation. So I believe first of all that the priority is the more of the patient selection is very important before going for a kind of a pre-decided mindset that whether I need to go for the conscious sedation, deep conscious sedation, or I should go for the general anesthesia. So if it is kind of we need a kind of the compromise airway, then better to go first of all the control the airway, because the comfort and safety is more important rather than kind of I need to do it in the conscious sedation and the general anesthesia. So this is one of the how I decide in my patients. So if my patients like airway is clear, there is no endobronchial obstruction, it's only the TE fistula, and there is no significant compromise, and then I need to put a Y stent, then effectively, and then I can go for a deep sedations because I need to just only open the stent and I can come out. But if I'm dealing with a vascular tumor, especially with the central airway, and it's at the carinal or at the kind of a tracheal level, better than kind of first of all we should use the rigid and GA for the conduit and then better control of airway, or then kind of then you can go for the procedures rather than going for a conscious one. If it is kind of it, then look like benign or polypoid lesion for the distal airway in the left and right, you can fair enough that that you can go for the conscious sedation. Second thing also very important in this one, the comorbidities are there, because the comorbidity also we need to, if the morbidly obese patient with the poor reserve of the cardiopulmonary, then definitely you need to think of that the patient if the patient is struggling for the breath and all, so how much when we are doing the procedure, how much the patient can complicate and how much we can control and then manage the airway. This is one important. Now third thing is there that if I'm going for a GA and then for the rigid, then both the are conventional ventilations and the jet ventilations, and depend upon then your availability and your comfort with your anesthetist. And whenever we are talking about the anesthesia, then always we need to discuss with our anesthetist then what we are going to do and what is our plan. So I think then it will be a better outcome and your comfort and also ease, and also it expedite the process in a much better way. And also we are ready for the post procedure, like I need to manage the patient in ICU, I need to extubate immediately on table and all these things. So these are the things very well can be managed in this way.
Yeah, excellent points, Dr. Rakesh. But for the audience here, generally, when you are a novice and when you want to do all these procedures, it's always advisable to do it under general anesthesia, because you have a controlled setting rather than venturing into conscious sedation. And sometimes patients can develop a massive hemoptysis, or patients can develop negative pressure pulmonary edema. So that's a real-time complication as well. Now we move on to Dr. Divyashri. So, what do you mean by a hot and a cold therapy in interventional pulmonology, and what are the indications? When will you use a hot therapy and when will you use a cold therapy?
Okay. Good evening, everyone. So cold therapy is basically cryo-related applications, whether it's for biopsy or for tumor debulking or for canal recanalization. Hot therapies is of three types. One is the laser. Second one comes the electrocautery probes, that is the blunt probes, or the snaring or the electrosurgical knives, along with APC. So APC is mainly used for bleeding control. When it comes to the knife or the blunt probe is again for the bleeding control. Knife is mainly during the stenosis, that you want to cut the stenotic membrane. And laser, we hardly use it in India. So
Yes,
very few
true.
centers have it.
Yeah, very true, Divya. And I think laser is something which is generally spoken much about in the literature, but I think most of the work can be effectively done even with an electrosurgical instrument, and that's what our experience has been. And laser, the problem is it's quite expensive, and if you're not very careful about it, you may end up causing an airway perforation, especially if you're not along the plane or if you use it in a little rash way. So now moving on to Dr. Saurav, like what lesion characteristics guide the choice between a hot and a cold therapy? Let's say, to put it, let's say I have a tumor, which is an endobronchial tumor, more like a broad-based tumor. So will your methodology vary? And when you have a pedunculated tumor, will your methodology vary?
Definitely. I think so. The question is very relevantly put up. So if you have a pedunculated lesion, I think so the best equipment, there is no comparison between a hot therapy versus a cold therapy. Snare is going to be the best equipment, because as Arjun sir has shown clearly, very nicely in his talk, that if you loop the snare firmly along the base of the tumor, you can easily cut the tumor in one go. And that thing, so I think so, give you a confident successful removal of a tumor within a shortest span of time. But the problem actually arises when you are having a broad-based tumor, and that too when you are not able to snare it. That is one. Second, you know that the vascularity of tumor is significant. Although cryo looks very, you can say very beautiful equipment when you are debulking these tumors, but the biggest trouble with cryo is bleeding control. As soon as you apply cryo, if you want to avulse that tumor, which is a highly bleeding tumor, you will have a problem of bleeding, and the next, I think so, 15-20 minutes is going to be wasted in controlling that bleeding. So in these modalities, we usually prefer a hot-based therapies. Like you go with the electrocoagulation electrode only. So there are very good electrodes with which you can coagulate the tissue, maybe char the tissue. If you are not thinking of doing a biopsy, if you have a confirmed diagnosis with that thing, once you have done enough amount of coagulation, then with the help of a cryoprobe, you can easily pluck out these tumors. So depending upon the vascularity of a tumor, I think so your choice of hot versus cold depends. Depending upon the location of the tumor, if the tumor is very distally placed, maybe in a segmental or maybe in a subsegmental bronchus, then using a hot therapy in these locations is sometimes dangerous. There, a cryo usually gives a better result. But if you have a central tumor which is in the trachea or in the bronchi, and with a good amount of bleeding expected due to the histology of the tumor, like a carcinoid or a squamous cell carcinoma, I think so hot therapy is something which should be preferred.
Yeah, excellent points. And for the audience, pedunculated, yes, it's always generally a snare, but sometimes you may see a tumor with a very broad base. In those cases, even if you try to snare it, you may not end up getting a complete snare of the tumor. And in our experience, what we noticed is whenever we snare a tumor completely, the best way to assess whether you have made a complete snare or not, you look into the color of the tumor. If the vascularity of the tumor decreases and it turns out to be a little pale, then probably you have cut the peduncle completely. Sometimes initially we think that we would have made a very good snare, but unfortunately you would have ended up partially avulsing the tumor. And then if you use a cryo for an extraction, it can sometimes result in torrential bleeding. And to Dr. Divya again, so now we heard about stents, we heard about equipments. So when you know that you are dealing with a benign or a malignant, does your interventional pulmonology strategy actually vary, or it is like you are going to choose the same stent despite of benign or malignant etiology?
So first, knowing the pathology completely changes our intent, because you will know how aggressively you will have to go. If it's a benign disease, you know that you have to mainly aim for cure or for a long-term airway preservation. But in case of a malignant lesions, you mainly aim for a symptom relief. Patient has come with central mass, you have to either debulk, give some relief to the patient. So it all depends on what is the pathology. For example, in case of hot therapies like APCs or electrocautery or the laser, when it's a benign conditions like a stenosis or a granulation tissue, you'll have to use short burst instead of activating the pedal for a long time, because that will lead into restenosis of the segments. So in benign conditions, you always prefer for a short burst or use a low power settings. When it comes to the stenting part in benign conditions, you always first prefer serial dilatation over the stent, whereas in malignant conditions, you can give them option of stenting right from the beginning. So knowing a benign versus malignant will change your modality, especially in case of stenting.
Yeah. So very good points, Divya. So the primary thing is when you are considering a benign, generally you need to consider the possibility of a surgical resection. So most of it is like with a curative intent. Whereas when you deal with a malignancy, as you said, it will be more of a palliative intent. So interventional pulmonology becomes a primary modality in terms of malignancy, whereas your surgical modality takes the precedence in terms of benign wherever it is possible. So now moving on to Dr. Arjun sir, is there any absolute and relative contraindication for using the hot therapy in the clinical practice?
Yeah, I would say that absolute contraindications are very few if at all. But one of the things would be where if you cannot get the FiO2 down, the patient requirements are very high. You are not able to get the FiO2 down at all. Wherein that it will preclude us from using any hot therapy. But again, whenever you're using something to control bleed, if you're not able to see, if you're not able to get a clear enough field for us to see where the bleed is coming from, it cannot be done, just like, carpet bombing in terms of, you don't know where the probe end is. It might be actually sticking into the place where it is, and you can have a torrential bleed because of the popcorn effect. So these will be the absolute contraindication. Relative would be that again when you may not be able to, and again the another thing, the other absolute contraindication will be specific to all the three modalities of thermal therapy. So again, you're going to be each one will have their own pros and cons. There are not too many other contraindications to using it, because a lot of times if you can use it, it actually makes our life easier. And one of the places where if you have a torrential bleed where you do not know where it is bleeding from, it can give you enough time would be if you can use a Fogarty or something to give a little bit of tamponade there, then go around with your scope and try and clear up some of the clots, give it that 2-3 minutes, and then so-called absolute contraindication becomes relative. So again, it changes from incidence to incidence.
Yeah, true, sir. And for the audience, as sir said, when your FiO2, you cannot bring it down effectively less than 0.4, then always be wary before you use these hot therapies, because you can cause an airway fire in these cases. And more so, what I found in routine clinical practice, whenever you're dealing with an endobronchial TB stenosis. So always be careful. You will be very enthusiastic in putting your knife and trying to make a nick, and sometimes you may end up even perforating your very fragile tracheal or a bronchial mucosa. And moving to Dr. Rakesh, so we heard about hot modalities. We had laser, we had APC, we had electrosurgical instruments. So in which of these settings you would prefer each one of these modalities? Dr. Rakesh, you're on mute, please.
So yeah, Dr. Arjun has shown about that. So all the hot therapies in the video, then how we use it and what are the best uses of that. And so APC, definitely it is for our superficial bleeding, and that is clearly endobronchial visible bleeding is there. Could it be kind of after the post removal of the tumor, base of the tumor? Could it be kind of any very small tumor, and that is the things that you can do, or somewhere you have taken endobronchial biopsy and then it is causing the patient is the coagulopathy, or like a patient is having any endobronchial hemoptysis and you see endobronchial lesion, that is the bleeding, where the APC is it's very, very, very important and very good tool, because it is rapid, non-contact and fast, and it could do. Now come to the other therapy where the hot, we use the snare and the cautery knife. The cautery knife, we use it for the endobronchial web. So in the patient of the endobronchial stenosis, then we use it, or sometimes then we try to remove it for some kind of tumor at the base of the tumor, or some of the large tumor, we are removing it. The snare, we have discussed that the snare generally when or the large pedunculated the tumor is there, and it could be easily kind of the snareable, and then it could be completely grabbed it. So now the snare we can effectively use it. and it gives us a good result. So, and fourth one is that as Dr. Saurabh has mentioned, the hot probe. This is also a very good tool because when we see, and I prefer rather than the cryo, as I agree with Dr. Saurabh, that because when we see the tumor and then because with the cryo, then probably the long avulsion can lead to the bleeding, especially with the carcinoid and squamous cell carcinoma and all the. Then hot probe it can give effectively because though it's a slow and it is a good thing then where we can do the coagulate and cautery and gradually reduce the tumor burden. And when we see that kind of a large area of the tumor has been in your cauterized with the hot probe, then later on the small pieces of the with the cryo you can effectively debulk the tumor, though it is a slow one. But then you can effectively, when you are not able to completely grab the tumor because of the broad base, and then it is largely covering the main bronchus, and you are not able to see the distal part, then you cannot go blindly there. So then hot probe can be used. So these are the some of the that important so aspects of that all these
Yeah.
modalities, and then all they work as a complementary. They are not exclusive that one can be used instead of others one.
Yeah, excellent points, Dr. Rakesh. So for the audience, APC is more like a superficial, more of like controlling the attaining hemostasis, whereas your electrosurgical has multimodality management, be it a snare, you can avulse a tumor, or you can use a knife for making electrosurgical incisions, or you can use the cautery probe for getting a hemostasis or coagulation effect. And laser primarily in the Western countries are used for tumor recanalizations and for some cases of a stenotic repair as well. So we move on to Dr. Saurav. So what are the best practices for minimizing the popcorn effect, which means like a tissue incineration during a laser bronchoscopy? So, and do you have like, have you started using laser in your practice as well?
Not yet. Had the option of seeing the laser when I was doing residency at AIMS. So saw few cases when Dr. Karan was using laser, but not have the opportunity to yet use it in my own clinical practice. Again, as Sir said, Arjun Sir said in his talk that because of the expensive cost of this equipment. And practically since last 4 years, we have been doing the central airway tumors, and more or less our work is being done by the available hot therapies as well as the cold therapies. So never found out a specific case where I could use this modality, which is laser. Now, to just theoretically answer this popcorn effect question, I think so as Sir has rightly told in his talk also that you should have to start with the low power setting. So power settings are the most important thing whenever you are using a laser. Try to keep the laser along the wall rather than at a perpendicular angle to the wall so that you can't injure through the wall. Then use a pulse mode setting because these both modalities of hot therapies and cold therapies, they come in pulse mode as well as continuous mode settings. So keeping that thing in mind, sometime when the tip of your laser probe is getting charged because of the effect of the tissue, cleaning that tip, sometime putting some saline onto the tumor so that the tumor remain moist so as to reduce the kind of popcorn effect. And again, reducing the FiO2 and reducing the prolonged firing. These are few of the steps which have to be theoretically taken with the laser to avoid that popcorn effect, whatever happens with these modalities. Although not
Yeah.
practically I've used it, so can't tell about my own experience, but I've seen and whatever we have read in the literature, these are the things which should be followed.
Yeah, excellent points. And the most important thing is when it comes to laser, which Dr. Saurav said, is never go totally perpendicular and always have a guarded approach. Never go for the full activation, which may end up in a perforation of your airway. And now we move to Dr. Divyashri. So we heard about APC. So how do you really use it? And what are the advantages of an APC? And where do you really find that APC will not benefit the patient? And how do you prevent complications with APC? So basically, what are the essentials of an APC that one should know before they start using it?
So first you keep a checklist. One, what type of APC probe you want to use, whether it is straight firing or circumferential firing or side firing. Then always put a neutral pad or a grounding pad to the patient. Keep the FiO2 less than 40%. Before you put the APC probe, clear the field of vision. You clear all the suction. Then when you start inserting the APC, you see certain markings on the APC probe. So the distance between the probe and the scope should be maintained, which is easily around 2 to 8 mm. Never touch the tissue. It is a non-contact modality, so never touch the tissue. The settings of the machine of the device should be around 30 to 40 watts. Keep the flow around 0.8 liter per minute, and use always short pulses. There are varieties of settings like the forced pulse, then short pulses, then coagulation. Then you keep the you start firing from distal to proximal instead of proximal to distal, and always suction the charred tissue. Reevaluate for the bleeding. So these are the few points which you keep as a checklist. Now, once you have done this, the pitfalls or the disadvantages is mainly the airway fire. If the FiO2 is not kept less than 40%, and you are continuously activating the APC probe. Gas embolism is second disadvantage. When you keep the probe in close proximity to the tissue, or you are continuously activating, airway perforation is airway perforation is one of the other complication. Major limitation is when the patient oxygen requirement is more, you should not be using APC. You have to use other modalities to
Yeah,
control the
excellent
bleeding.
points, Dr. Divya. So basically, it's a non-contact mode. And another important thing as a early practitioner, what you should know is the black mark should be beyond your
Scope.
vision. If not, possibly the probe is very close to your scope, and there are chances it can cause a damage to your scope as well. And mostly, I think we generally use the end-on APCs in most of the centers, but you have a sideways APC as well as the circumferential APCs as well. So now we move on to Dr. Arjun sir. So explain to our audience about the procedure of how to use an electrocautery. What are the practical steps, sir?
Electrocautery in general, or what do you? Yeah, I think
So, like, what
all
are the
thermal.
precautions we need to take? Because generally we don't know what is the watt settings. We don't know what is the padding for the people who generally start using it, because most of it are generally used by the surgical colleagues, and they're used to this bipolar devices rather than the monopolar, which we generally use in our practice. So what are the prerequisites that a person should know before they venture into using, especially what is a cut mode, what is a coagulation mode, and what are the hybrid modes that we generally use in our day-to-day practice?
Yeah, so whenever using an electrocautery, again, you can contact the surgical colleagues. Initially they can help you out with the initial settings. Again, we generally tend to go between about 30 to 40 watts is what, if you're going to be selecting, and we usually select this and leave it there. And whenever you're in doubt, you tend to use more of coagulation rather than cut. Or if you do not have a combined sort of mode, you can use cut and coagulate alternatively. And the cut is primarily used when you're using electrocautery knife, and there it has to be very, very short bursts. And there has to be, like I've already not talked about in the talk, it has to be a very, very short burst, and there has to be a good coordination between the person somebody else will be assisting you, in terms of pushing the knife out so that the knife is out fully. And either you can have control over, one way to reduce the confusion would be you have control over the, cautery pedal, and you can take very, very short bursts. Whenever using an electrocautery knife, do not use it on the posterior wall. And when you use when you use a snare also, and when you have taken most of the tumor, again use cut and coagulate in sort of alternate fashion, or you can use coagulation first. So this will help in taking care of the feeder vessel, which can be there at the base of the tumor. And with the APC, with the advent of FET, we are hardly using any of the blunt probes anymore.
Yeah, excellent point, sir. But somehow the problem with the APC is it's like an add-on cost until and unless you have a gastro suit, which can actually get it for you, because most of the work, and the lucky part is your electrosurgical instruments are routinely available in your OT setup. Only thing is we need to have a little bit of knowledge about it, and the probes, consumables alone, you need to purchase it as an extra. So even at our center, we use more of this electrocautery tip for coagulation. But the problem with that coagulation tip is it's a contact mode. So sometimes it gets soiled with the debris, and when you try to pull it out, you may end up causing minor bleed as well, and that becomes like a on and on phenomenon. You coagulate, you pick up, bleed comes, again you coagulate, pick up, bleed comes, and later you need to put a tamponade to control the bleed. So I think if you have the luxury of an APC, then it's always worthwhile to have one, because it comes handy whenever you are dealing with this superficial bleeds. So when using electrocautery, so this question is now to Dr. Rakesh. So when using an electrocautery, how do you manage the risk of char buildup on the probe? That's what we were discussing, and how does it
Yeah.
affect your energy delivery?
So, Dr. Vishwesh, this is very important topic. It's a practical aspect is there. So, as so we have discussed about that the charring is one thing. Just when we contact this the electrocautery, the probe or the knife, when we touch it, so then immediately the tissue desiccate and the carbonized. Now the question comes because when the tumor is wet and there is water content is there, the maximum energy is transmitted to the tissue. Okay. Now the problem happens because if we do not clean it and we keep it kind of the charring is there, the black things are there, still we keep on doing the procedure and then we keep on kind of pressing the things. Ultimately, the energy, because then what are the machine happens, because machine has a kind of auto things where if it deliver that, if the electricity is not delivered, the voltage keep on upping up. And when the voltage is coming up, then it rather than desiccating the tissue or cutting the tissue, it keep on hotting the probe. So when the probe is then kind of a more of hot, it causes the kind of a delayed perforation because it is in contact with something, and later on then kind of your popcorn effect and bursting of this tissue. So whenever we see the charring or in our knife or the probe, we should remove it and then we should clean it, because then in OT we have seen then kind of they have scrub things, we can clean it and then use a saline to clean it. But then after that you can repeat it use. Second thing also to how we can decrease the charring, as we have discussed earlier also, keep the contact because it's more of the pulsed or intermittent. Never do the contact of the 3 to 4 seconds. When cut and pause, cut and pause. This is the best way. Then we can decrease the chances of our char development. So decrease the development of char, and when we have char, then we should not keep on continuing our probe, the contact one, because it will lead to the more chances of the damage to your airway or the normal tissues. Or second is the kind of it could be scope, because it is more hitting the probe rather than kind of delivering the energy to the tissue.
Yeah, excellent points, Dr. Rakesh. The important thing is when you note the buildup of the debris always, but don't immediately pull it up. Sometimes it may be still hot and it can affect your suction channel. So wait for some time and then pull it back and then clean up your tip of the probe and then redo it. And to Dr. Rohan, are you there? Dr. Rohan?
Yeah.
Yeah. To Dr. Rohan, so what are the precautions which are essential to prevent an airway fire during a hot therapy? Okay, till Dr. Rohan joins, to Dr. Arjun sir. So we have been seeing a lot of these cases of central airway obstruction. So if at all you want to give one tip to the audience, we still have a lot of questions, but one tip to the audience who starts new, because you are so excited seeing all the videos and everything about central airway. So what would you suggest to them?
Right. So, you need to make sure that you get a good control over the airway. I think that's what it is, and take it slow. And you need to have a plan in place, and you need to have a plan B and plan C in place, because whenever you have a central airway obstruction, nothing goes according to plan A. You need to have a plan A, plan B, plan C, and probably plan D in place also. And it's always good that, especially when you're starting off, and now that across India, there are almost every city has got an intervention pulmonologist. You may be able to find somebody who's your friend, who's your colleague in some other thing, who can come and help you out, because two brains are better than one in terms of trying to think on your feet when things go wrong, when things don't go according to plan. So yeah, it's good to get excited about, but you need to be prepared you always prepare for the worst, and you try and get whatever the best that you can do.
Yeah, excellent point, sir. And I think the best way to anticipate all these complications is you start visualizing before you actually do the procedure. So you are already your reflexes are full hand.
Yeah, this
Once you face.
visualization should get you to be better prepared, and it should not stop you from doing the procedures.
Yeah, exactly. Excellent point, sir. And now we move to Dr. Saurav. So how do you actually manage a highly vascular endobronchial tumor? And most probably, let's say that you are thrown up with a case with an carcinoid. So what are the precautions you are going to take before you venture into doing a tumor debulking?
First of all, I will hope that I won't get a highly vascular tumor when I'm doing a central air intervention.
So
If
I
it's
wish you get for your next case. So how are you going to handle it?
So the one thing which I totally agree with Arjun sir is that these tumors, the first and the most important thing is control of airway. And when you're starting new, I know there is not availability of rigid bronchoscopy with everybody, but if you have the access to that thing, I think so that is the best conduit in dealing with these kind of tumors. Because going in again, coming out, and especially in those patients who are just on spontaneous ventilation, where you have to cross the vocal cord every time, I think so that is the biggest challenge when you are dealing with a highly vascular tumor. So rigid bronchoscopy with a good control of airway, I think so that is the best attempt. Some people argue that they can use an endotracheal tube, but again, as sir showed in his talk, that with an endotracheal tube, the lumen of majority of the tube is being taken by the flexible bronchoscope, so aeration is not going to be good. Again, passing even a 6 mm scope through a 8.5 mm tube is going to be sometimes challenging because of the resistance faced. You can use an iGel or an LMA, yes, definitely that is also going to work. But again, if there is a bleeding, then again, if the bleeding is tremendous in amount, then also sometimes your vocal cord and everything gets flooded, and you won't be able to negotiate through this. So first and most important thing which we ensure at our center is we use always a rigid bronchoscope, unless and until it is absolutely contraindicated. Somebody has a very limited mobility, limited mouth opening where we can't put a rigid. So in those cases only we prefer an ET or an LMA. So that is one thing. Then next, as it is a highly vascular tumor, we usually start with the hot therapy. As Rakesh sir has also said, and I have also told in the previous part, that we usually try to first coagulate some amount of tumor if it is a broad-based tumor. Because if it is a suppose pedunculated tumor, or if snare is able to be looped around it, then that is the best thing which can happen for a intervention pulmonologist. In snare also, as Arjun sir was also saying, that when you are snare some tumor, you have to alternately use coagulate and cut. We usually prefer to more coagulate than cut. Somebody have a habit that they even keep on pressing the cutting mode only, and they forget that there is a coagulation pedal also along with it. So what we commonly do, if we take a 5-second cycle, we 3 seconds do a coagulation, 2 seconds only do a cut. And then be very gentle while you are using even a snare, because if you are very haphazard, if you are doing it very rapidly, sometime even you can cut the tumor properly, but there can be a tremendous amount of bleeding. When there is a bleeding, the first thing that should be ensured is the ventilation of the other lung. What we always focus about is the lung in which the tumor is there. We keep on just suctioning the lung, and we forget that there can be a bleeding which is happening and which is going on to the other lung. So again, repeated suctioning of other lungs should definitely be preferred. Cryo seems to be a good modality, but again, for carcinoids which are highly vascular, using a cryo directly without any coagulation will eventually lead to a tremendous amount of bleed, which is going to happen. There are even data suggesting some amount of embolizations being done for these tumors prior to planning, but not yet we have been able to use those things. And last, just 2 key points. Do not attempt these things alone. Always you need to have good intervention pulmonologist in the side of you, because once it starts bleeding, your mind goes blank. So sometimes you are not even able to judge what should be done next. So there should be a capable guy standing with you, doing an intervention with you, who should be your support. And you should always have plan T. As sir said, ABCD, there should be a plan T. Plan T is a thoracic surgeon, because if anything goes wrong, at least you should have a backup of a thoracic surgeon at your center who can take up the job from where you have left, in which situation you are not able to manage the patient properly.
Yeah, excellent points, Dr. Saurav. And if it is a carcinoid, don't get excited and jump and start doing it. And very clear, rigid should always be there, especially when you are attempting to take biopsies or do a tumor debulking of these patients. And I think Dr. Arjun sir has a point to say. Yeah, Dr. Arjun.
Yeah, I think just add a couple of points to whatever Saurabh was saying. Is that one of the things that you have to be very careful when you're using a snare, because snare is being controlled by somebody else outside, and when they close the snare, and when the when somebody else is using, it's better that they have control over the snare foot pedal also. And otherwise, what can happen is there can be a thing where you're doing a manual cut when the snare foot pedal is not getting pressed. So this can lead to a significant wound, because a lot of these tumors, when you try and cut them manually, especially carcinoid, will just cut through, and then you'll have a lot of bleed. And the only place where I would not agree with Saurav would be the fact that a thoracic surgeon is very, very unlikely to help us out when things go south, because they go south very fast, and it's very difficult that, though, yeah, it does help our conscience to know that somebody's got our back, but I don't think so that person is a thoracic surgeon.
Yeah, excellent point, sir, Arjun sir. And I think plan D hardly works, because when you're in a crisis and you call a thoracic surgeon, there's actually no time to do anything. Like if you are in a crisis, it's just a matter of seconds, and your reflexes and your visualization only matters a lot. And to Dr. Divyashri, so in which situations would you use more than one hot modality treatment? Is there any situations where you want to use both an electrosurgical knife, along with that you wanted to use a APC, along with that you wanted to plus or minus a laser?
Especially in malignant central tumors wherein you have snared but the base is still bleeding, you can always use an APC to control the bleeding. So that is one of the condition wherein you can use both two types of hot modalities. One is the snaring and second one being the APC or the blunt probe to control the base from the bleeding. Generally, two types of hot modalities are avoided in the benign conditions because they will tend to cause a lot of stenosis. Preferable to use only in malignant conditions if there is a lot of bleeding.
Yeah, good. As Dr. Divya, can you hear me?
Yes, sir.
Yeah, as Dr. Divya said, like sometimes you may need the two modalities, especially you use a snare and then you want to coagulate with the APC. But I don't know, we have never used a laser, so I don't know where it would be a practical approach in using a laser as an add-on to it. And now to Dr. Arjun sir again. So what are the key mechanisms and advantages of cryotherapy, and when do you prefer cryo recanalization over tumor debulking or a thermal debulking?
So yeah, I think cryo is when you are sure that the tumor is not vascular, or sometimes where Saurabh I think just touched on it. We've had tumors. See, we look at it in two ways. One is the airway compromise. Second is bleed. So you can probably handle one of the two. When they both occur together, you're gonna have a huge issue. So sometimes we, like Dr. Ravi says, it's a pathology of neglect in our country. We've seen tumors which have started growing from the right side, crossed over the carina and gone on to the opposite side. One side is already gone. Now the other side is 70% gone. There, you probably have to handle that, and then you find that this is a vascular tumor in terms of carcinoid. Then these are cases wherein we have had a couple over years wherein we have gone ahead and embolized them and then taken them up. And then you have embolized them in the last 24 hours or so, and you know that the embolization is good. There you can go ahead and use your cryo to debulk them. And the other place where you have to essentially use a cryo to debulk is if you have a broad-based tumor, which is there in the left side, or deep down in the right lower, where you cannot advance the rigid barrel. You don't get the access to advance the rigid barrel, and you have a broad-based tumor. Essentially, you have to take it out. There, you go ahead, bite the bullet, and do a cryo there. Where again, the cryo is going to be. It has to be multiple attempts. And usually what we tend to do is it's obviously always through the rigid, and it is not what we'll be discussing here. And then we usually have what is called as, we have a Fogarty in place. So the person who's handling the Fogarty will deflate the Fogarty, you do a cryo. As you are coming out, the Fogarty gets inflated again. This is one way wherein we can use, the tamponade effect is there. When you come out, take out the tissue. Again, it takes at least 12 to 15 seconds for you to take out the tissue and go. So these are places where you are forced to use cryo. It's an excellent tool because it can, you don't have to, it has a 360-degree catch. So you just have to touch the tissue and you are able to debulk the tissue. And sometimes what happens is you have an overhanging tumor. You are able to go below the tumor, lift the tumor up, so that the cryoprobe doesn't touch the mucosa, and then you can sort of avulse the tumor out. Again, all these things are excellent if you know that the tumor is not going to bleed. So usually we'll have a few tentative small bites with the cryo. If the tumor is not bleeding, then we get a little bit more bold and go ahead and take it out with the cryo. And again, when it is not amenable to anything else, and you just have to get the tumor out, we essentially have to use this modality and accept whatever bleeding. We'll have to handle them. And you probably spend that 5-6 seconds taking that cryo out, and then spend the next 15 minutes trying to control the bleed that you've caused.
Yeah, excellent point, sir. And the thing is, tentatively taking one bit of biopsy sometimes can become a very dangerous thing as well. Like sometimes you take a bite and it turns out to be a carcinoid. Then sometimes
No, we're not talking about tentatively taking. I'm talking tentatively debulk slightly first, and then you go ahead and You basically decided to dine with the devil. So you'll have to do what you got to do. Yeah.
True, sir. And now to Dr. Rakesh. So describe the procedure of using a cryoprobe for a recanalization. So we know cryo devitalization. We know that cryo recanalization, cryo ablation, cryo extraction. So what does these terminologies actually mean?
So I think Dr. Arjun has explained some of the things, though. So I will again that kind of reiterate something. The first thing that commonly that safest the use of the cryo is more of the cryo ablations that we use, and I think nowadays we prefer and in the benign tracheal stenosis, where earlier we used to do the cautery, and now we try to then kind of avoid of the cautery knife and all, and we used to do that kind of a long freeze and thaw, and that is the one of the cryoablations for the granulation tissues or the kind of the benign stenosis, because it has been shown that it reduces the chances of the again fibrosis and restenosis. So this is one of the cryo long ablations at the long freeze and up to go to 20 seconds, 30 seconds, because we know about that the cryo is more of the cartilage is cryo resistant. So that's why you can go effectively on the granulation tissues. So later on, then it's more of the delayed. It is not for the rapid one, but it is kind of the base one where that you do not want the immediate airway opening. That's one of the important. Second, the cryo extractions we have discussed one that when we are debulking the tumor. So one important thing only then for the bleeding, because then try to keep the time short, because initially when we keep it for 3 seconds, maximum 3 to 4 seconds, it's okay because then remove the tissue. But then because it's more of 360 degree, Dr. Arjun explained that once we keep on kind of a time longer, it's the 360 degree, it's keep on kind of devitalize and the tissues and start involving the other vessels and all. And when it goes more than 6, 7 or 6 second or 8 second, then it completely avulge, and then that time then chances of bleedings are more because you are moving the complete tumor and not kind of a piece of the tumor. So the one important thing is that with the cryo debulking is the keep the time short, but obviously it's a time taking procedure, because every time you're coming out, remove the tissue, and then Fogarty, then again deflate, and then see the bleeding, and again going for that. So this is one of the slow procedure because you are not able to do with the snare and all. So this is one of the two, because for the endobronchial, I think, I believe these are the commonly we use it.
True. Yeah. And with this, as an extension of this question to Dr. Rohan, so we use this freeze thaw cycle, and we believe in this delayed cytotoxic effect of the cryo. Do you really use it in your clinical practice? Like you just go, you see a central airway tumor, you just freeze thaw without extracting, allowing it to go in for necrosis and then slough off, or you just directly go for a cryo extraction?
We usually go in for a cryo extraction. As a later part, when you do a check bronchoscopy, where the residual tumor, maybe with the freeze thaw, there is something which is there in debris which is there, you can always remove it. But most of the time, when you're doing a debulking, you would want to do a cryo extraction rather than the freeze thaw. Most of the time, it's going to be cryo extraction, not the freeze thaw.
Yeah, very true. Even in our center, we generally don't do it because sometimes it can cause a delayed bleeding. Once you discharge the patient,
Yeah.
they can have a
Yeah.
hemopsis, and sometimes you may not have a very clear free tumor margins.
Even
And to
after
Dr. Saurav,
you know,
how do you manage the bleeding during and after cryo extraction?
So first, I think so the assessment of the kind of tumor is the most important thing. Like you have been talking a lot about carcinoid. So for a carcinoid, never attempt with a cryo. Maybe attempt with a hot therapy. I think so that should be the answer to it. Second is maybe when we are planning to do with a cryo, I think so taking a small piece of a biopsy with a normal biopsy forceps sometimes gives you an idea about the bleeding of tendency of that tumor. If the bleeding tendency of the tumor is significant, I think so coagulation first, followed by a cryo should be there. Third is the conduit is very important when we are using a cryo. So there should be a conduit whenever we are using cryo, especially for debulking, because it has to be multiple time pulled out and multiple time it has to be pushed in. So maybe rigid, maybe followed by an LMA, maybe followed by an endotracheal tube. That should be the sequence of a conduit which should be used. Simultaneously using a Fogarty whenever we are taking a biopsy with cryo is something which helps in a lot way. Because the best, I think so, attempt to stop a bleeding is by a tamponade effect. If you have a balloon which you can inflate as soon as you have taken up a cryo biopsy or a cryo tumor debulking you have done, after that you inflate a balloon, that is the best thing which can be done. Regular suctioning of the bleeding lung as well as the non-bleeding lung where the blood is getting soaked is something which we should always ensure when we are having a bleeding while using a cryo. Sometimes people use cold saline, tranexamic acid, adrenaline. A lot of things have been done on the tumor or on the actively bleeding site. Sometimes they help and sometimes they don't even help also. But again, frequent suctioning is something which should be always done, especially just post procedure, and an immediate removal of the cryo, immediate removal of the tumor from the cryo probe, removing the probe from your scope, and immediately going inside to assess. There should not be any much delay while you are removing a tumor, because sometimes a delay of even few seconds can cause the vision to be so bad due to the bleeding effect that eventually when you go inside you are not able to use any of your hot tool also, because there is so much of bleeding. And as Arjun sir also said, if there is a bleeding area thoroughly present in the airway, do not use an APC or do not use an electrocautery. It won't work. First, you have to clean the vision after the bleeding settles, or after the vision is cleaned. Then only these modalities, maybe an APC or maybe a hot therapy, will work in that area.
Yeah, excellent point, Dr. Saurav. But something which we started using in our practices, especially when you want to do this tumor debulking, make sure you put the patient on a reverse trend Lindbergh position. So generally what happens is even if the bleed comes, it doesn't, to a certain extent, it doesn't contaminate the distal lung. Second thing is we always use a suction by the side of the rigid inside the barrel of the rigid bronchoscopy, a pediatric suction tube. So that helps you to suck the blood that's coming. And we always use a Fogarty, like Fogarty on one side and a suction catheter on another side. That's something which we started using. And very rarely we use something called as a double Fogarty technique. So one Fogarty through the working channel of your rigid bronchoscope. And then when you want to go a little more deeper and provide a tamponade, you deflate this and go with the working channel of your flexible bronchoscope and use the Fogarty to control and provide a tamponade effect. So I think it's all like customized and it depends upon your center and an experience. But important thing to notice, make sure you secure the airway before you think. And sometimes reflexly, what I have noticed is when you are new and when you see a bleed in a rigid, you sometimes are in a hurry to remove the rigid because you see the saturation falling and then you are in a mess because you lose the airway. So never be in a hurry to remove your rigid until you have a backup plan, because that provides a lot of space for you to work upon and control the bleeding. So now we move on to Dr. Divya. So what is the role of a delayed cryotherapy in malignant central airway obstruction?
So delayed cryotherapy mean the cryo is applied to the tumor, but you don't remove the tumor immediately. Generally, this is done in conditions wherein the central tumor is not causing critical airway obstruction, or the lumen is greater than 50% still patent, or if the patient is not in any respiratory failure or not in stridor. Mainly done in a patient who's really not fit for a prolonged procedure, or if there's any high risk bleeding of the tumor like a renal cell carcinoma or a thyroid malignancy or melanoma. Of late, I think this is less being done. We immediately extract the tumor. So delayed is something which you apply the cryo, but you don't remove the tissue immediately.
Yeah, I think as we said earlier, generally we don't follow it. Like more, even though we speak about it in an Indian scenario, most of the time we generally don't follow it because sometimes these patients never come back to you. The moment you do a procedure and they go back, it's not that they're going to come back to you at a later date. It's not like 100% guarantee. So they generally
Yeah,
don't use this.
so I mean, so I want to say one thing. So it is not for the tumor; it's more for the granulation tissues for the stenosis and all. Especially that is not critical. But
Yeah,
definitely for
of
the
course.
tumor, it is not. Yeah, tumor,
Yeah,
it is not.
not to be used. Yes. And again to Dr. Arjun sir. So what is the recommended post-procedure observation time? So let's say you do a procedure. When do you feel? When do you go actually to the patient and say that attended that your patient is safe?
I think over years now we still can get a little enthusiastic and try and declare it before all things are fine. So I think the earliest that you would do when a patient is under GA is when your anesthetist says that all is good and the patients come out. So especially with these patients, when you have a central airway, difficult central airway, either a tumor or you've just taken out a stent, that's more like it because we don't know how the patient is going to react. You find that the procedure has gone well and you go and say to the patient that all patients attend all is well, and then the anesthetist says that they're not able to get the patient out. That can happen on and off. So I think best would be to try and wait till the patient comes out of anesthesia and the patient is able to patient is comfortable. So that will be the earliest that you can say, and by and large we'll at least observe these patients for a lot of these patients can over time we feel that we can do the procedure and discharge them at the end of the day, especially we do it in the first half of the day. You can probably send them home by the end of the day. But by and large, any patients under GA, we will observe them for at least 4 to 6 hours after the procedure before we say that we're good. And one of the other thing, especially with elderly patients, when you're taking a lot of these patients under GA or deeper sedation, is that a lot of them go into, especially male patients, go into urinary retention late in the day because the GA will sort of push their BPH up and we say that all is good and the patient lands up in the middle of the night back with us saying that the patient has got a urinary retention. So it's not only to do with getting back from whatever they came to you with. You also have to be mindful of the fact that you put them through GA and they have to recover completely from GA. Yeah.
True. Excellent point, sir. And delayed pulmonary edema is it's not an unknown complication. Sometimes you do a procedure, patient is quite stable. Then later you see that the patient landing up in a pulmonary edema, respiratory distress. And sometimes patient may slowly go in for a muscle fatigue and then they go in for a retention of CO2. So I think as long as the patient starts walking and going back home, I think any time during the course is going to be a complication. More so when you do a stenting. Sometimes the stent can migrate, the patient can have an hemoptysis. So all these things has to be taken care of. So now we move on to Dr. Rakesh. So what are the key indications for an airway stent placement in your
So the key indication for the stenting is there because for the mixed growth or the extrinsic compression. And when if we are able to, when we are remove the tumor and still the kind of a significant amount of the tumor remains there, and then you have not able to achieve more than 50% of the lumen patency. That time you might require a stent as these things. We need to keep in mind that because when we are putting a stent, so for what reason and what kind of the stent we are using, because for benign disease that we need to keep in mind, we need to remove the tumor stent. So that's why we will put in that mindset. And as we have discussed, I think earlier, so indication for the stenting in a benign disease are like post-intubation tracheal stenosis or post-tracheostomy stenosis, when even 2 to 3 times we have done a dilations and the patient is not fit for surgery because of the comorbidities or because of the some anatomical location of the your like subglottic stenosis and all, then we should go for either of that, your T-tube or Montgomery T-tube, or then we can go for a silicone stenting. That is one of the indication for the silicone. And nowadays for the malignancies where it might respond to the your chemotherapy and radiotherapy, there even you can try for the silicone stent also. But for the metallic stent, then that's we need to keep in mind that it is more of the palliative care, so that it only extend that your life and quality of life, that is more important. Because when there is a your the extrinsic tumor because of the your surrounding, could it be a kind of a large your thyroid malignancies or esophageal malignancies, along with that your fistula or kind of a critical stenosis, or that so all these kind of the tumor or the any kind of a large lymphoidal tumor or lymphoma that was causing the compression, then you might require the stenting in a patient as a palliative care to that to recanalize the airway. So these are the things we need to keep in mind, because once the patient is on with the stent, there are potential for the complications, because more and more the patients survive with the stent, and then you are going to see and you are liable for dealing with all the kind of challenges and complications with the patient, because as you said that very difficult to for all these patients to be in a follow for the regular kind of follow bronchoscopy and all. So when these patients survive for a longer, and we with the stent and all, we should keep in mind that discussion should be very clear for the patients that we are putting a stent, because after a time then it becomes as your foreign body. So the patient should understand very well that kind of why we are putting a stent, and then he need a kind of regular follow-up for the that kind of upcoming and potential complications, and we can deal it proactively.
Yeah, excellent points. And now we move on to Dr. Rohan. So how do you decide between a silicone and a metallic stent, and what are the prerequisites that come into your mind when you want to choose between these two stents?
So broadly speaking, most of the times, if you are dealing with benign conditions, you would want to use a silicone stent. In malignancies where you're looking at palliation and stuff, covered metallic stent would be the choice with which you would go in. So this is mainly the areas where you would want to decide between a silicone and a metallic stent.
Yeah. And now to Dr. Saurav, we know now we have through the scope stents, and I think we had used it for a couple of patients only. So what is your experience, and when do you really prefer it over a conventional stenting procedure?
So I think so. When the issue is with rigid bronchoscope, you don't have a rigid bronchoscope. When you want to do a bronchial stenting, then and you have the availability of this through the scope stents. When you want to just do it with the help of flexible, I think so that is the situation where we practically prefer it. Otherwise, whatever stent we have been using in the past, the only problem when you put up a stent is negotiating through the airway, and in the same conduit you want your bronchoscope and your stent to be there. So if you can put up a bigger size rigid like a 14 or a 12 size rigid, you can easily negotiate both your scope as well as your stent through any of this. Once there is a problem, you don't have a rigid. If you want to do it through the help of a flexible, then comes the role of these through the scope stents, where you just want to put a flexible into maybe right main bronchus or left main bronchus, and you want to pass your through the scope stent into that area. So there is practically a more utility of these through the scope stents rather than your conventional stent. Again, when you are using a flexible, you have always the option of using endotracheal tube. And nowadays, there are companies which have come up with even conventional stent, not through the scope, but of smaller size. Even 3.5 mm size conventional stents are also there. So that can easily pass through an 8 mm tube when you have a thin or an ultra thin bronchoscope along with it. So you can both negotiate it through an LMA. Also, recently we have done 2 or 3 cases in which we have used an LMA, where we have used a 3.5 mm bronchial stent with a thinner scope which goes through side by side through each other. If you have the availability of fluoro, then also even if you are using a 6 mm diameter stent deployer, you can pass it through an endotracheal tube of 8.5 mm size, and in the fluoro guidance you can do it. So if you have nothing of these sort of things available, then yes, the preference for a through the scope stent definitely comes into a picture. Or if you have a patient in whom you can't proceed with any of these things and you just want to be under with minimal sedation and you just want it to be done with the help of only a flexible bronchoscope, then again there is a utility of through the scope. Otherwise, all other conventional stents we have been using over the period of years together with any of these permutation combination through ET, through LMA, through rigid, and when nothing of these you don't want to do it, directly as sir has shown that using a laryngoscope, passing first the guide wire through the bronchoscope with the help of bronchoscope and then passing a deployer through the vocal cord, simultaneously taking your bronchoscope or taking the help of a fluoro can be helpful in putting up a stent.
Yeah. So, but Dr. Saurav, when we used it, actually since we got so used to doing a rigid and stenting with a bronchoscopy by the side, we found actually through the scope stenting little complicated for one reason. You will not be able to see where the stent is actually getting deployed. Only you will be seeing it in the C-arm. It looks like as if like you will have a direct vision, but at the end of the day, you realize like the vision is actually blind, and you need to rely entirely on your C-arm for exact positioning of the stent. This has been our observation. And Dr. Arjun sir, what is your take on this? Because for people, it looks like quite simple, like through the scope, it's quite easy to do. But actually, you end up having no vision. You just see the deployer passing through the working channel, and you have to entirely rely on your C-arm when the stent is getting placed.
Yeah, I mean, so that's why I had to borrow the video from Dr. Janaki, who's placed it. We've not placed it at all. So I think I can understand the thing because you're only seeing the distal part of where it is getting deployed, and then you'll have to probably pull it back up. No, it makes sense. I think yeah, through the scope is the only thing is that you're able to get beyond the end of where the distal end of tumor is with your scope, and then you'll probably have to rely on the C-arm to deploy the stent. I think, yeah, it makes sense.
Yeah.
In our case also, like recently we have done 3 cases of this through the scope. In all the cases, we ensured that we push the scope through the stenotic area and try to place it distally. Because again, you know that pulling a stent is still an easier job as compared to if you have placed a proximal stent and then pushing it again back into that area. So the company people also, whosoever comes to deploy this, they also always say that thing, either use a fluoro or try to place slightly distal to the area, so that even if you require to pull it, that can be still a possible option, but rather than pushing the stent through that area.
Yeah,
But
and
I
the
don't
important
see
thing is
that
never
fluoro.
believe the person who comes for deploying. You need to learn it by yourself, because many a times they are more like half cooked than a fully technically trained
Almost
professional,
all the
and
time they are
you
half
may even
cooked.
end up having a nightmare when the stent is being placed, because as a novice you generally rely on them completely, but never do that. Like, you need to know how to deploy your stent properly. And to Dr. Divya, like we know that we do a lot of tumor debulking and stenting. So would you prefer a stent in all cases, or what are the specific indications of a metallic artery stenting in a malignant central artery obstruction?
Post debulking, if the tumor is again regrowing, you can always prefer for the stenting. Then second could be the esophageal malignancies, wherein in the first go only you've seen that it has already infiltrated the airway and patient has come in a critical condition. You at least first debulk and then plan for a stenting. Malignant cases, most of them requires stenting, so so
Yeah, true. Like generally it depends upon the nature of the tumor you have, whether it is a purely an intrinsic growth, or it's an extrinsic compression, or it's a mixed variant. Generally, when the tumor is like totally pedunculated and you have a clean margin, you generally don't end up stenting. But when you have a mixed sort of tumor, or when you have an extrinsic compression, let's say you have a lymphoma or something, then possibly in most of these cases you end up doing an airway stenting. So now again, our question is to Dr. Arjun sir. We heard about a Y stent, and what is your technique of doing a Y stent? And you prefer a single guide wire or a dual guide wire? And do you do it always with a rigid, or only with a laryngoscope along with a flexible bronchoscope by the side? So how do you really place it at your center?
Yeah, I think before I answer this, and I'll just add one more point to the previous thing. Again, it will also depend on the type of tumor. So if you are dealing with something like a mucoepidermoid or adenoid cystic,
True.
you wouldn't want to go ahead and stent these tumors. So basically, you want to see whether the tumor or the patient is going to outlive the stent. So any of these stents, you're going to have complications in about 6 months' time. So if the time to re-debulking is more than 6 months from whatever the tumor biology, what you think is, or if you're not sure and you're able to take everything out, probably you can give it the first time, debulk and come out, especially if it's primarily endobronchial with not significant sort of extrinsic compression. Go ahead and do that. And if the patient comes back, within a couple of months and you have to do it again, then this will be the point where you can probably do debulk and put in a stent there. Or the patient doesn't come back to you for 6 to 9 months, I would still consider that now we debulk again and again rather than place a stent. So that's one thing. And now when you're talking about Y stents, we always, like I said, we always use a rigid bronchoscopy. The only times that we've had to deploy Y stent is when we had under flexible is when we've done it at the periphery where we do not have an access to No, it's not at our center where we have done, and in emergency situations where we have gone ahead and done. So we would again prefer to use you know, two guide wires to deploy the stent. I know it leads to a lot of intermingling or intertwining of the guide wires. So we usually start off with two, and then if we find that no, it's causing a lot of issues, we probably dump one guide wire and use only the left guide wire and go ahead and do it. And we generally tend to use fluoro because it's at our disposal. It gives us a better sort of it gives you an additional guide to deploy the metallic wire. And we would essentially need to use the largest rigid barrel possible, preferably use a 14 to take it across, because the deployer for any of these Y stents, unless until you're using a very small Y, something like a 10, or 14, 10, 10, where you can probably go with a smaller thing. But the usual 16 or 18 that we use, the thickness of that is close to, I think, 8 to 9 mm. So you essentially need to use a 14 barrel, and even with the 14 barrel, you need to have probably an ultra thin scope going by the side of that, because you usually will not take a regular, either an ultra thin scope or a pediatric Hopkins is what you probably need to go by the side.
Yeah, excellent point, sir. And one thing is, for people who are initially using the stent deployment through rigid and you want to simultaneously visualize it, never use your routine working scope. Sometimes when the stent is getting
It will not
deployed,
work anymore.
yeah, you will be out of work after possibly the stenting. So what you can essentially do is you can pass single use, which is never a single use. Most of the time it becomes like you can use your possibly this cheap available scopes by the side, so that in case if you end up getting a trauma to your scope, you still don't lose your working scope. And now we move to Dr. Saurav. So what are the most early and the late stent related complications? I think that is hardly ever spoken about, because we show the fancy part of the stenting, but I think best stent is always a stent that was never placed. So what are the complications you deal with? And recently, to be honest, I had one complication of a 12-year-old placed stent, and it was a nightmare both for the patient and for me. And luckily, we had a successful outcome, but maybe another day it could have been in a disastrous consequences as well. So, what are the complications you see in your practice?
The most common complication I would say is cough. So sometimes these patients come with an intractable urge to cough. So they always keep on coughing whatever cough suppressant, nebulization, saline nebulization, mucinex, and anything, whatever you give, the irritating sensation of that stent inside keeps them coughing. So that is, I think, so the most common complication which we in our day-to-day practice face. The longer the size of the stent, the longer the person mucosa is not in contact with the mucus, whichever is the patient is producing. So again, coughing out that mucus becomes a challenge to these patients. Usually you put a metallic stent in a patient who is terminally ill, who is having malignancy. So overall their cough reflex is already poor. Overall they are not able to bring out their secretions. And now with stent in place, these patients starts drowning in their own secretions. They will come to you in your OPD having a gurgling sound, that sound of air coming out through the secretions always there. You just do a check bronchoscopy, you clean out those secretions. Again, 15 days later, the same patient will land up with you in a hypoxic state, maybe again do those secretions. So that is the second big problem. Asking these patients to do a physiotherapy regularly, to cough out those secretions, maybe use an oscillatory device, is something which becomes a challenge. As soon as the stent grows older, then the complication with granulation tissue comes up. As Sir Arjun sir said, that 6 to 9 months is something which you expect for a stent life maximum is to be there. So if there is a patient who is maybe not going to survive beyond that, then I think so that is the ideal candidate for a stent to be placed. For tumors where you expect a person to be growing longer, maybe living for 1 year, 2 years, 3 years, then again this complication of granulation tissue is something which comes up in a big way. Sometimes these patient granulation tissue even starts bleeding also. So these patients might come to you with complaint of hemoptysis. And not, I would say rarely, but yes, you have frequently seen stents being migrated. You have frequently seen stent being fractured also. So it all depends on what kind of patient selection we have chosen. The more frail patient is going to have more trouble with the stent. And if there is a tumor in which the person is going to be expected to be live longer, maybe like 1 year, 2 year, you will see more of these complications which are going to be there with these patients.
Yeah. So now I think since we are running short of time, we wanted very quick answers from the panelists here. So how do you manage a granulation tissue and restenosis after stenting, Dr. Rakesh? Very quick points, practical points for the audience.
So the granulation tissue, because more that keep the stent, because one is the that if we see the granulation tissues that is causing the significant stenosis, then better you go for the hot probe or the kind of, and or either you can use the cryo also to reduce the, because if it is kind of milder one, you can use the cryo, and if it is kind of significant stenosis, then you need to kind of recanalize the airway, then you can use the hot therapy.
Yeah. And to Dr. Rohan, I think a very tough question. How do you approach a near complete airway obstruction in an unstable patient? I think the best is you give it to the surgeon if possible. If not, how are you going to handle it?
Not always. Also, if there is hemodynamic instability as well, it's going to be very difficult. But if you can do a tracheostomy, if it is possible, do that. If
Yeah.
not, you'll have to take up the rigid, pray that everything goes well, do a mechanical
Yeah.
debulking, secure the airway, and then deal with the residual tumor.
Yeah, very true. Something which is often less spoken about is when you have a stenosis, the simplest thing you can do is you can ask your ENT, they'll do an awake tracheostomy. They'll do whatever you want above the tracheostomy. But if you are very aggressive, then sometimes you may end up causing a catastrophe on a table. So now we move to Dr. Saurav. Like, how do you handle a migrated stent that has moved into a distal lobe? Like, what quick answers?
I think so. Using the biggest possible forceps with you is going to help you in these kind of migrated stents. If you can use a rigid forceps, then I think so that is the easiest thing, because the bigger the size of forceps, it is easy for you to pull that stent if it has migrated distally. If you don't have a rigid bronchoscope, if you don't have a rigid forceps, then I think so using your gastro colleagues, whatever forceps they are using, these are bigger in size. They can hold your stent firmly, and when you are pulling it out, then you can easily pull these stents back into the stenotic area. And sometime when you pull it out altogether, if you want to just remove the stent and you want to place a new stent, then in those situations also using a bigger size forceps is the answer to these things.
Yeah, so it's easy to say, but once you remove, you end up having a nightmare as well. So, last question of the panel discussion before we take the audience question to Dr. Divya. So, what key mistakes should early interventional bronchoscopist avoid? I think this is the most pertaining question which needs an answer. Yeah.
First is the case selection. Second, you discuss the CT in detail with the radiologist. Always don't go by just the CT films. Ask the patient to get the CD, and then discuss with the radiologist as which segment to go, how much is the luminal narrowing. If there's any luminal narrowing, also looking for the VBN protocol. Then other checklist. First, you go with the check bronchoscopy on day one. Don't plan for all the therapeutic interventions on the same day. First, do the check bronchoscopy. Keep adult bronchoscope and pediatric bronchoscope both standby. Fogarty's check whether the balloons are getting inflated or not. Check whether the suction is fine. Then cryoprobes. Always freeze and see whether the cryoprobe is getting activated or not. When you're coming for hot therapies, make sure that the FiO2 is less than 40%. We get confused during the procedure as which pedal to press. Also, sometimes yellow is for cut, blue is for coagulate. Then always prefer short bursts instead of continuous activating. Then suctioning. Sir, I think others can add on.
Yeah, very true. Like the important thing is have the checklist. Maybe if you don't have the checklist, you may end up in a nightmare, because the problem happens is like you go unprepared, and that is where the most of the complications happen. So having a proper checklist, communicating to your assistant and to your anesthetist, and the most important thing is counseling the patient. You got to be brutally honest to the patient. Sometimes you are very excited that you want to take up the case. You give them unrealistic hope and you do the procedure, and then you are caught by the neck, don't know what to do. So I think you have to be brutally honest about the outcome to the patient, whatever it is. And I think these little things can actually save you from a nightmare situation which will happen post procedure. So now we have a quick audience questions. We'll start with Dr. Arjun sir. What is the role of microwave coagulation therapy? Dr. Tarun from Delhi. Any ideas? Sir? Like, I have never used it, so I'm not sure.
No, I don't think so. It is available for use. I think probably the microwave is more for management of it's one of the modalities that is being discussed for management of early lung cancer. I don't think so. It is available for no general use. I think probably still in
Yeah.
research.
Yeah. And now we move to Dr. Saurav. This is a question from Dr. Uday from Bombay. What is APC and how does it differ from electrocautery? 2 quick points.
APC is a non-contact modality and electrocautery is a contact modality practically. And APC is usually for superficial lesions, and when you want it for a deeper kind of ablation, the electrocautery.
Yeah. And Dr. Gaurav from Indore, the question is to Dr. Rohan. What is electrocautery snaring? Just a brief.
So it's basically used for pedunculated lesions so that you can completely take the lesion off. It basically goes around the lesion and cuts the lesion along with coagulation. So that's how it works.
Yeah. And to Dr. Divya, Dr. Hitesh from Ghaziabad, indications for cryotherapy via a foreign body.
Indications for cryotherapy via foreign
Via
body.
fiber optic bronchoscope. I think I said the answer. So,
Okay.
yeah.
Okay. One is when you're doing the transbronchial lung cryobiopsy, again, you'll be using a rigid conduit. Second is for foreign body removal, especially the organic foreign body removals, and then for endobronchial biopsies.
Yeah. And now again to Dr. Rakesh, Dr. Gopal Krishna from Bangalore, in mixed intrinsic eccentric airway obstruction. How do you sequence the hot therapy, cold therapy, and the stenting?
Obviously, first of all, the first aim is to recanalize the airway and remove and restore the patency of the tumor. If it is a mixed tumor, definitely then once the recanalizing, better to go for a stenting. And same thing with the broad-based tumor. And first then mechanical because of the mechanical debulking, and later on with the cryo, the piecemeal, and base with the use of APC to coagulate for the base. And later on then you put a stent because then it is obviously it is extrinsic component is there, so you need to maintain the patency and also control for the hemostasis also.
Now we are going for the rapid fire because we have lots of questions. To Dr. Arjun, Dr. Gurpreet from Mohali, how does the depth of tissue necrosis differ between APC, laser, and cryotherapy?
Depth of tissue is only a couple of mm in terms of ABC, and both of the other things have higher depth of tissue penetration. Again, with electrocautery, depends on the length of the knife. However long the knife is, you will be able to penetrate, and however deep the snare, you'll be able to take it through. As far as laser is concerned, it's a lot more. That is why you need to be parallel to the wall rather than perpendicular to the wall, so that you don't cause any tissue injury which is in the beyond the wall.
Yeah, and Dr. Joy from Cochin, this is to Dr. Saurav. In bleeding malignant airway obstruction, when does hot therapy become contraindicated despite active bleeding?
I think so, Arjun sir, I've already said this thing that when the FiO2 requirement is very high, then is the situation when it absolutely becomes a contraindication. Sometime when the tumor is actively bleeding, I think so clearing that bleeding first becomes an indication where you can use a hot therapy, because if you're going to use a hot therapy directly on the blood, it's not going to work. So just high FiO2 and clearing out the bleeding first and then using it, maybe you can use it in any.
And sometimes when you have an arterial spurt, be careful while using an APC, you can cause a gas embolism as well. Though it's a theoretical thing, never we have seen, but still. And Dr. Sohan from Calcutta, and this is to Dr. Rohan. How does airway cartilage involvement alter the modality choice?
Airway cartilage involvement, basically, cryo can be used with cartilage resistant. Then we can use both modalities. You can use the hot therapy as well as cold therapy, depending on the situation.
Yeah. And Dr. Suraj from Nagpur, and this is to Dr. Rakesh. How does prior radiotherapy change tissue response to hot and cold endobronchial therapies?
Obviously, that's because radiotherapy that slightly increase the vascularity of the tumor.
Yeah, and another thing is sometimes, especially when they give the neck radiotherapy, you have to be careful. Putting the rigid might become a major problem. Yeah, and bleeding, as you rightly said, bleeding is something which can be torrential. And Dr. Anil Bhai from Surat has asked, how does gas flow rate affect depth and spread of APC injury? And this is to Dr. Divya.
So if the flow rate is more than 1.5, then the penetration to the airway is more, so you can cause airway perforation. So always keep the flow rate somewhere between 0.8 to 1.5 and not more than that.
Yeah. And Dr. Satish from Chennai, and this is to Dr. Arjun again. When should the electrocautery snare be avoided despite a pedunculated lesion?
I don't know.
I think it is a
There is no.
carcinoid. Better avoid and send it to your son.
I think pedunculated carcinoid, you would want to take it out, man. Why you send it to a
We want to
surgeon? Why
take
you
it
to
out,
get
but
it out?
sometimes it's a nightmare only. So, yeah, true, sir. Generally, we do it. Yeah. So, and Dr. Devesh from Aligarh, why can APC cause airway perforation despite being a non-contact technique? To Dr. Saurav.
I think so. It doesn't usually cause. Matlab, I've never seen maybe.
Yeah, generally it doesn't cause. The depth
Really
of
doesn't cause.
penetration
It is
is
actually
hardly any.
laser which
Yeah.
cause more of a this, or a knife which you have used, it can cause
Until
an
and unless you are with full intention to cause an airway
to cause a
trauma,
airway tear, exactly.
then it can cause, yeah. And Dr. Ramesh from Delhi, and this question is to Dr. Rohan. Why does cryotherapy usually not provide immediate airway opening, unlike laser or electrocautery?
No, it does provide immediate airway opening. When you're doing cryo debulking, it does give you immediate
Yeah,
clearance.
it does. It does actually.
So,
Yeah, true.
yeah.
Yeah. And Dr. Sandeep from Bhopal, why is high FiO2 the single most risk factor during heart therapy in bronchoscopic therapies? To Dr. Rakesh.
So because it caused the airway this kind of fire, because
Yeah,
that's a
because
more
oxygen is a very good medium for combustion.
you can have a blast and then this one serious injuries.
Yeah. True, very true. And
Scope
Dr.
damage also.
True. Dr. Kunal from Kanpur, this question is to Dr. Divya. Why is cryotherapy ineffective in a pure extrinsic airway compression? It is, yeah.
There's nothing to debulk there.
Exactly. Like you don't have anything to work inside with your working channel. It's all like outside your working channel. Yeah. And Dr. Ravi from Ranchi, why should thermal therapies be avoided distal to the metallic airway stent? This is to Dr. Arjun sir again.
Yeah, I think, see, it's not only that. Most of the things, it's a covered metallic stent. So you got a silicon cover on top of the metallic stent. Again, when you use a thermal therapy, it can heat up the metal too. So you don't know how much heat is getting transmitted. So these are the two things. So when you have a silicon covering, you have an increased risk of airway fire, as well as there can be the metal which is getting heated up and can cause tissue injury.
Yeah, sometimes airway fire as well. You can see the spark literally when your cautery probe touches the metallic airway stent. And Dr. Harpal from Bhavnagar, in which scenario is cryorecanalization preferred over conventional cryotherapy? To Dr. Saurav. I think we touched upon it. Anyway, one word.
So I think so. Conventional cryotherapy, the person wants to ask is that if you just debulk the tumor and just keep it there itself. So in those which are peripheral lesions where you don't want an immediate airway opening, where you don't want an immediate clearing, you can use a conventional cryotherapy. But where there is a lesion in the main bronchus where you want an immediate opening of the airway, then a cryorecanalization is definitely preferred over a conventional cryotherapy.
Yeah, true. And Dr. Sachin from Mumbai, this is to Dr. Rohan. Why does laser therapy require stricter safety protocols than electrocautery? Quick answer.
So increased depth of penetration.
Perforation.
Perforation risk is always there. So that's fine. And if you continue, if it's a prolonged pulse, the depth of penetration is too high. So it's going to be short pulses and away from the lesion. And depends on what you want to do.
Very true. And Dr. Alex from Trivandrum, this is to Dr. Rakesh. Why can delayed airway obstruction occur after cryotherapy despite initial procedural success? Generally not, but yeah.
Generally not.
Generally not, but sometimes if you just do the cryoablation, maybe edema can set in after quite some time. Yeah, Dr. Ajit from Nashik, this is to Dr. Arjun sir. This is to Dr. Divya. Why does APC have superficial penetration despite effective hemostasis?
It can penetrate. It's non-touch, so the depth of penetration is only
low because it works upon the plasma as well as the heating up of the plasma, which causes the coagulation. So it cannot penetrate deep. Yeah, the true. And Dr. Sagar from Varanasi, this is to Dr. Arjun sir. Why is patient selection more critical than technical skill in FOB guided stenting? If you want to get avoided from a medico-legal, then yes, the answer is yes. To Dr. Arjun sir.
Yeah, I think patient selection is important, and of course, when you both are extremely important. But again, you should not get irrespective of where you are in the learning curve. Patient selection is always important. You should not be doing more harm than good.
True. And 1,000 good cases never speak about you, but one bad case can make a dent in your career. Yeah, true. And Dr. Arup from Howrah, this is to Dr. Saurav. Why are silicon stents more prone to migration than metallic stents?
I think so. No radial force in the silicon stent. Sometimes
Yeah.
smooth outer surface of silicon stent, and sometimes the size mismatch. You have dilated the airway to a significant size, but you have put up a silicon stent which is small in size. These are the things which makes the silicon stent more prone
True.
this migration.
And Dr. Piyush from Jaipur, this is to Dr. Rohan. What are the considerations for choosing a stent type? I think we dealt upon it.
Yeah.
So
Again, if it's going to be in for a shorter duration, you can use a silicon stent. Retrieving becomes easier. For benign conditions, definitely a silicon stent. For malignancy and palliation, you're going to use a metallic stent, a covered
yeah,
metallic.
so benign silicon, malignant silicon, or metallic, depending upon what you really want. Yeah. And Dr. Rakesh, again, Dr. Kamaljit from Amritsar. Can cold therapies be repeated if needed? I think the answer
Yeah, we
is
can repeat
yes.
it. Yeah.
Yeah, the
Yes.
answer is yes. And Dr. Mamtej from Lucknow to Dr. Divya, how do comorbidities impact choice of therapy? Yeah, very good point, actually. When you have a comorbidity, let's say you have a pacemaker or you have something, would it impact actually?
Especially for the hot therapies, sir.
Yeah. So I think you can call this pacemaker guy. I think he does some sort of a
Changes.
switch
Mhm.
modulation, which makes
Mhm.
it compatible. I think I'm not very sure about it. Dr. Arjun, sir, any take on this, like from your side as well?
Yeah, usually you talk to the cardiologist who put in the pacemaker and ask whether the electrocautery can be used, and if he'll tell you what are the settings that you can go ahead and use, and you can also usually he'll also get in touch with the pacemaker guy. So yeah, that's a word.
Yeah, true. And Dr. Nagarjun from Hyderabad, and this is to Dr. Arjun sir again. Why is laser therapy contraindicated in highly vascular tumors without prior coagulation?
No, actually, see, laser is a way to coagulate this one. So it's not contraindicated per se. Highly vascular tumors, laser would be the way to go because you devascularize the tumor first. You use a lower setting to sort of coagulation, devascularize these tumors. But it can be it can take a lot of time. So that's about it. So you need to make sure that you're able to ventilate these tumors. And suppose you have a very vascular tumor in the trachea, you probably will have to take something distally across, continue ventilation, and then go ahead and devascularize these tumors, and then even carcinoids can be taken down.
True. Now we are going for ultra rapid fire because I think the questions are piling up. So Dr. Naveen from Meerut, this is to Dr. Saurav. What are the potential future directions for airway stenting?
I think so. 3D printing, so that absolute match of the size of the stent with the airway. Biodegradable stents are something which are the potential future directions.
Yeah, and I think for people, if they don't know, like Dr. Varun from PSG is actually had made a Indian-made silicon stents, which is quite less priced and easily affordable for the patients as well. I think there are many innovations happening. I think he is also working on 3D printing as well. So I think a lot of innovations are there. And Dr. Matthew from Coimbatore, can FOB therapies be personalized for patients? And this is to Dr. Rohan.
FOB therapy is personalized patient. I'm not very clear as to
So
what.
I think each patient has to be personalized. You can't have a blanket approach. So that's the answer possibly. And Dr. Atreya from Guwahati to Dr. Rakesh. What is the post-stent cuff? Sometimes a marker of correct stent positioning. Wherever you put the stent, the patient is going to cuff. So can it guide you whether you put the stent
No,
correctly?
it's very important because sometimes then it is more with the proximal area, especially with the kind of near the vocal cord and subglottic area.
True.
It
And
causes the kind
Dr.
of intractable cough.
Exactly. And Dr. Kundan from Dhanbad, this is to Dr. Divya. Why should benign airway disease be a relative contraindication for metallic stents? Good question, Dr. Divya.
One, metallic stents difficult to remove if at all, if you have to later. Causes lots of granulation, tissue, bleeding. Very difficult to remove, sir. So,
True. And I think the problem happens this is a very, very important question because if you put a metallic stent for a benign disease, you have to remove it within at least 3 months. If you don't remove it, it's going to become a complication, a lot of granulation, stent fracture, and that itself will make the stenosis worse. So never put a metallic stent for a benign etiology. And in case accidentally, if you had put or if you have seen a patient having it, then remove it at the earliest, whatever is possible. And why does FOB guided stenting require a wider safety margin than a rigid bronchoscopy? Dr. Sunny from Patna to Dr. Arjun.
I think because you do not have any control over the airway, and you do not have now what if it fails, right? If you have a stent deployed and not in position, then you are in soup.
Yeah, true. And Dr. Saurav, Dr. Samar from Noida, what are the common complications of FOB therapies, hot, cold, and stent? One complication, the major complication they should know. Hot therapy,
with hot and cold, hot therapies, again, the chances of airway fires,
fire, cold,
cold again, bleeding is a common thing.
bleeding,
And
stent.
granulation tissues. Most
Perfect. Done. So, Dr. Nikhil from Raipur to Dr. Roshan, what are the commonly used hot therapeutic modalities during flexible bronchoscopy? Quick point
APC,
answer.
electrocautery.
Yeah, true. And Dr. Kundan from Dhanbad again to Dr. Rakesh, how do you manage stent migration or malposition?
So important things are, so use the kind of the most with the rigid forceps is one of the best one, because then you can
Yeah.
control the stent position very well, because it has a good force to deliver at a distal area. If it is not there, then you can use pull the lasso from the kind of a
Yeah.
regular forceps, and you
True.
can slightly pull it up. But
True.
then better you do it under the fluoro again, so you can see the mobilization and use it, because otherwise you are not able to see the distal
True.
part.
And the most important thing is when you are pulling, do it very guarded in a corkscrew. Never try to pull it. Sometimes the stent may come along with you. So, Dr. Heathen from Ahmedabad, this is to Dr. Divya. Can FOB therapies be used in post-transplant patients?
Definitely.
Definitely, the answer is yes. And Dr. Muthukumar from Chennai to Dr. Arjun, what are the indications for using hot therapies during FOB? Quick answer, sir. One or two indications.
Yeah, tumor debulking, stenotic,
Repair, granulation.
Yeah, granulation.
And Dr. Manjinder from Ludhiana to Dr. Saurav, what are the signs of stent fracture or failure?
I think so. Reappearance of breathlessness and stridor sometime, whatever we started with, again coming back to the same symptoms, maybe a sign of stent failure, which has been happening now.
Yeah, and Dr. Sanas from Trivandrum, this is to Dr. Rohan. Can granulation tissue be prevented or managed? So, what are the precautions you will take?
Basically, people use application of mitomycin and steroids and stuff, but no robust data.
Yeah, true.
Otherwise,
And I think
there's nothing
surveillance
else that-
bronchoscopy actually helps, or
Yeah.
even imaging or a symptom assessment actually helps.
otherwise there's
And
no specific therapy which can prevent
Yeah,
the granulation
true.
from happening.
Dr. Pankaj from Faridabad, and this is to Dr. Rakesh. How do you manage airway edema post FOB therapy?
So, first important thing is the kind of keep your the procedure time less. This is one of the important point. And second thing is this, some of the the procedure steroid can help, and also the nebulations can work.
True. And Dr. Rajnikant from Trichy. So, in which clinical situations are cold therapies preferred over hot therapies? Dr. Divya?
Cold therapy over hot therapy.
Foreign
When
body,
there is
maybe?
foreign bodies,
Yeah.
when the risk of bleeding is
Yeah. So,
mainly
maybe foreign bodies and for transbronchial lung biopsies, and even for cryo extraction. Yeah. And Dr. Dipinder from Rohtak to Dr. Arjun, what are the risks of respiratory failure post FOB intervention?
Yeah, if you have now multiple, you can have vocal cord edema if you are going back and forth multiple times, or if you've had a difficult rigid intubation, or now you've not managed to clear the secretions adequately, or no, the patient has had a bleed which you have not recognized, and the patient has had a lot of clot inside, and these are all the things where you can have hypoxia and patient collapsing after the post-op period.
And Dr. Bobai from Guwahati to Dr. Saurav, which airway lesions are most suitable for FOB guided stent placement?
I think so. Straight stent placement, which are present in the bronchi, maybe Y stent, which has a bigger diameter, we should be preferring a rigid guided placement rather than.
And Dr. Himanshu from Udaipur to Dr. Roshan, what follow-up is needed after FOB intervention?
After fiber optic bronchoscopy, we basically would monitor the patient for at least a couple of hours to make sure that they are comfortable, vitally stable, conscious, and mobilized. So that's what you're going to watch for.
Yeah, I think we'll take last a couple of questions. Dr. Durgadas from Patna to Dr. Rakesh. How does tumor debulking facilitate airway stent placement?
So first of all, that because before putting the stent, we should adequate recanalize the airway, but make sure about that if you are if you are not able to recanalize the airway more than 50%, then your stent will be well placed. Because if you completely remove the tumor and there is no extensive compression, there is no point to putting the stent, because it will definitely
true. And Dr. Nidish from Pune to Dr. Divya, how do you decide on repeat intervention in case of a stenting? So when do you do a repeat intervention?
And if the patient has come back with complaints of stridor, you want to look in for whether there is any granulation tissue or migration.
Yeah. That's the most common. Sometimes mucus impaction can also present in these patients. Yeah. And to Dr. Arjun sir, Dr. Varun from Jamshedpur, in patients with a high risk of bleeding, which therapy is preferred and why? I think Fogarty balloon would be there. Dr.
Yeah,
Arjun,
I
sir?
think you'd use thermal technique, preferably a snare if you can take it out. Yeah.
Yeah. True. And if at all you want to have a tamponade, then possibly a Fogarty. Generally,
Fogarty, yeah.
that's what most of us use. And Dr. Omkar from Thane, and this is to Saurav. What are the post-procedure considerations after airway stenting? Very good question. What is your institutional protocol on this?
So usually we say key chest physiotherapies has to be continued. Some kind of airway positive pressure devices has to be used so that they keep on suctioning regularly. Surveillance bronchoscopies has to be done frequently.
Yeah.
These are the things which should be done for
True.
every patient whenever we are doing the stenting for them.
Yeah, and to Dr. Rohan, how does airway edema differ following a hot and a cold intervention?
We don't see too much of edema immediately after a cold intervention. Most of the times, I think
I think generally following a cold, some amount of edema we get, right? Like maybe with a hot, it results in more of a delayed airway edema.
But it's not too bad.
But I think generally we don't see that much. We don't see that much of
the edema is mostly because of the trying to get the airway. The rigid may cause the edema and subglottic we have just been.
It's not more because of the
Yeah. And I think one last question, and we'll end with Dr. Divya. Benign airway stenosis, what is the preferred approach and why? Dr. Harith from Hyderabad.
You try to cut with the electrosurgical knife, dilate.
So would you prefer a surgical modality or a bronchoscopic modality? So how do you place these two modalities in a benign airway stenosis? Let's say we have a post-intubation or a post-tracheostomy stenosis, one spectrum, endobronchial TB, another spectrum. So how do you position surgery versus an interventional pulmonology procedure?
So if the stenosis, it's not a complex stenosis, then you can try to do it with the bronchoscopic guidance with electrocortical surgical knife cut and dilatation with the balloon. But if it's a very complex stenosis and the
recurrent as well,
recurrent, you can go in for the surgical.
For surgical management. And for endobronchial, most of it is bronchoscopic, but there are few centers which claim like they do this resection and then they attach the left upper lobe to the main trachea, anastomosis they're doing. And Dr. Arjun sir, like in endobronchial TB, have you seen such experiences where the surgical modalities are helpful? Because somehow we feel like these are more like multi-level stenosis and you need to keep them doing repeated dilations. And is there a role of surgery? Because I heard from few centers they do the anastomosis of the left upper lobe or the right upper lobe to the main airway. So any experiences at your center?
Yeah, I mean, if you can find a surgeon who will take it up, because we don't want to keep dilating these patients. So
yeah,
we can find a surgeon who can take it up. So we've got Dr. Saronan here with us, who's done a few cases wherein now he is able to, though he's an oncosurgeon, he's able to do such complex cases wherein he can go ahead and reimplant these bronchus. But these cases are few and far apart because now the patients usually tend to have both tracheal as well as bronchial involvement. So here, the patient selection is extremely important. So if you select and send the patient to the surgeon would say that they would be able to operate. The surgeon is skilled, but selecting the cases is entirely up to you.
True, very true. And I think we are done with the questions. I think we have crossed much beyond the time of the web meet. And I think we had excellent discussions from all the panelists and an excellent talk from Dr. Arjun sir. And I think we'll call it up for the day. And thanks everyone for a patient listening. And thank you to all the panelists for their excellent inputs. Thank you one and all.
Thank you very much.
Thank you. Good night.